All right, let's dive into a topic that, let's be honest, can be a real headache in medicine: adrenergic receptors. If you've ever felt totally lost trying to connect these receptors to what's actually happening with a patient's hemodynamics, you are definitely not alone. But what if I told you there's a simple key that makes it all click? Well, let's unlock it together. Oh yeah, I've been there. You're staring at these charts, trying to memorize everything. This one increases afterload, that one decreases preload, another one does something to cardiac output. It just feels like a random soup of facts, right? Well, the good news is it's not random at all. There is a system, and we're about to make it incredibly simple.
And here it is. This is the simple key that changes the entire game. It's just three little associations. Ready? Alpha is for pressure. Beta 1 is for the pump. We're talking the heart itself. And beta 2 is for the pipes. That's your blood vessels. That's it. Pressure, pump, pipes. Remember that, because it's the framework we're going to use to decode everything else.
Okay, so let's get started with the first piece of our key. Alpha equals pressure. We're about to see just how alpha-1 receptors are the absolute masters of squeezing the system to really crank up that pressure.
The mental picture I want you to have, the thing you should burn into your brain, is this phrase: clamp down the circulation. Just for a second, forget all the technical terms, and just imagine a giant, powerful clamp tightening around the entire vascular system. That, in a nutshell, is exactly what alpha-1 does.
So let's look at how this clamping actually works. On the artery side of things, alpha-1 causes vasoconstriction. What does that do? It increases systemic vascular resistance, or SVR, which is really just the force the heart has to push against. You know it as afterload. But at the same time, over on the veins side, you get venoconstriction. Squeezing the veins literally pushes more blood back to the heart, which increases the volume filling up the ventricles. We call that preload. So you see, by jacking up both afterload and preload, alpha-1 gives you this powerful rise in blood pressure. So why do you care about this in the clinic? Well, think about it. If you have a patient in vasodilatory shock, where their blood vessels are all relaxed and floppy, what do you need to do? You need to clamp down the circulation. That's exactly why a pure alpha-1 agonist, like phenylephrine, is your go-to. But you got to be careful. If you crank that afterload up too high, a heart that's already struggling might not be able to pump against that resistance, and you could actually decrease cardiac output. The body can also fight back against all that pressure with something called reflex bradycardia, where it slows the heart rate way down.
Okay, on to the second part of our key. We've just clamped the system down with alpha-1. Now, let's see what happens when we focus on beta-1, which is all about one thing: powering the pump.
So, here's your mental shortcut. If alpha-1 is that big systemic squeeze, beta-1 is all about the engine itself. It makes the heart pump both stronger and faster. It's really as simple as that.
So, how does beta-1 power the pump? Well, its receptors are located mostly in the heart, and when you stimulate them, they do two main things. They increase the heart rate, that's what we call chronotropy, and they increase the force of every single contraction, which is inotropy. A stronger, faster pump naturally means higher cardiac output. And hey, as a little bonus, it also triggers renin release from the kidneys, which helps support blood pressure even more.
And the clinical logic just flows perfectly from this, doesn't it? When would you need a stronger, faster pump? Well, when the pump itself is failing, like in cardiogenic shock, or for a patient who has a really low ejection fraction. This is the exact scenario where a drug like dobutamine, which really zeroes in on those beta-1 receptors, becomes the tool you reach for.
All right, time for the last piece of our key, and honestly, this is the one that seems to trip people up the most: beta 2. So we've gone from pressure and pumps to pipes. And with the pipes, the function is basically the complete opposite of what we've been talking about so far.
The key concept, the only thing you need to remember here, is to open the pipes. Forget about clamping, forget about squeezing. Beta 2 stimulation is all about dilation, just opening those vascular pipes wide open.
So while alpha-1 constricts, beta 2 does the exact opposite. It causes vasodilation. And this happens almost exclusively in the arterioles, the little arteries. By opening those up, you dramatically decrease systemic vascular resistance, which means you're decreasing the afterload. All of a sudden, the heart has a much easier time pumping blood out. And here's the crucial detail. Unlike alpha-1, beta 2 has almost zero effect on the veins.
Okay, this is such a classic point of confusion, so let's just put them head to head. Beta 1 is the pump. It's in the heart, and its job is to directly increase rate and contractility to boost cardiac output. Simple. Beta 2 is the pipes. It's in the arterioles, and it opens them up, which decreases SVR and afterload. You see the difference?
One works on the engine, the other works on the roadway ahead. Getting that distinction down is absolutely key.
So we have our key, right? Alpha is pressure, beta 1 is pump, and beta 2 is pipes. Now let's put it all together and see the hemodynamic payoff. This is where the magic happens and it all clicks into place.
And here it is. This is the payoff. Let's just walk through this chart using our simple key. First up, alpha 1, pressure. It clamps the veins and arteries. So what happens? Preload and afterload both go up, and the net result? Mean arterial pressure goes way up. Perfect. Next, beta 1, pump. It works on the heart to increase cardiac output, so CO goes up, which also raises MAP. It doesn't really touch the vessels directly, so preload and afterload are kind of neutral. Fits perfectly. And finally, beta 2, pipes. It opens up the arterioles, so afterload goes down. And what does that do to blood pressure, or MAP? It goes down. See? See how our simple little key unlocks every single one of these outcomes? It's awesome.
And there you have it. No more trying to memorize a million disconnected facts. Now you have the key. You can look at any clinical problem and just ask the right question. Is the problem a weak pump? Well, that's a beta 1 problem. Are the pipes too leaky and need some clamping? That's an alpha 1 job. This simple model gives you the power to actually reason your way to the right answer every single time. So the next time you're faced with a patient in shock, what's your first question going to be? Is it the pump or is it the pipes?